Hello, hello, hello. As always, probably nobody's here at the moment, so we'll let people come in slowly. Deirdre's here. Hey, Deirdre. Hope you enjoyed the conference. So if you're just joining us, which you are because we just started, please say hello. Let us know you're here. Tell us where you're from. And I don't know, favorite bottled water, since Steven's drinking one, and it was the first thing that came to mind. So what do you like? I can't stand Dasani. Fuji's good. Liz likes LaCroix. Um, Valerie, hey Val.
PG.
Fiji. Oh, I thought I heard something. I'm sorry. So we have an extraordinary panel with you this evening talking about the future of OCD treatment. So if you're wondering where it's all going, you've come to the right place. So as always, we take a couple minutes and let the room fill. Hi, love Lana. It's good to see you. Buxton. Joe, I like Buxton. Is Buxton a water? He laughed afterwards. Maybe the joke's on me. Oh, I'm from the UK. Well, UK. I now want to Google Buxton. Hey, it's Don from DC. Hey, Don. Deer Park water. Okay. Is that the guy that comes with the jug and puts it on your thing? This is fun. I love water. Like, that's all I drink. So this is very exciting for me. Dave. Hey, Dave. Justine is here. Hey, Justine. We do this every time. Matthias, but I'm not 100% sure. But wow, what a team tonight, he said. So excited. We have Petros from Naxos Island of Greece. Welcome from Greece. Alex says, hello, Dr. Goodman. So if you're just joining us, I'll just quickly say, I hope you guys, if you came, enjoyed our second annual IOCDF online conference this past weekend. Just a quick update, we had nearly 2,500 participants from over 43 different countries, including Argentina, Australia, Cyprus, Honduras, India, Hong Kong, Lebanon, Korea, United Arab Emirates, just to name a few. So it was a spectacular weekend, 3-day weekend full of content and support and recovery. So thank you if you joined us. Hi, Beth. Hi, Susan. I just squeaked. That was interesting. Puberty just hit. I've been waiting all this time. So with that, I think we're about 2 minutes in. If you're just joining us, please say hello. Let us know that you are here and where you're from. And please continue saying what your favorite bottled water is, because I'm super curious. With that, let's get through. We've got a big night ahead of us. So let's get through the housekeeping so we can get into the good stuff. So my name is, well, first of all, welcome to the Roundtable Future of OCD Treatment. My name is Ethan Smith. I'm a national advocate for the International OCD Foundation, which simply means I have OCD and I won't stop talking about it. We have a bit of, it's new for some people, I guess. Real quick, the Roundtable is intended to serve as educational content and is not intended to replace therapy. For treatment-related questions, please be sure to work with your local provider or contact a local clinician. International OCD Foundation is not a crisis hotline, should not be used if you're in distress or feel unsafe. If you're in a crisis or you're ever feeling suicidal or unsafe, please go to your local emergency room, call 911 or call the suicide prevention hotline at 800-273-8255. As always, we want to create a safest space as possible and be respectful and kind of others. So please keep that in mind as you're leaving comments. We are here to support one another. Also keep in mind that this is a public platform on various social media platforms. So as you ask questions or leave comments, I don't know that we'll be getting to many questions today, but please feel free to ask questions. And if we see anything that applies to this particular roundtable, we will definitely jump in, but please keep that in mind. All right, so with all of that, I think Buxton is only available in the UK, I think, so maybe that's why you don't know it. Yeah, does anybody know Buxton bottled water? All right, we'll do a roundtable on.
I Googled it, so.
You know now, all right, well, perhaps we'll do a roundtable in the near future. Hi, Liz. Liz Smith is here. That would be my mother. Not Steven's mother, incidentally. So with that, let me get to our amazing guests, and then let's jump into the future of OCD treatment. So first, I would like to introduce Dr. Carolyn Rodriguez. She's the Associate Dean for Academic Affairs, Stanford University School of Medicine, Associate Chair for Inclusion and Diversity in the Department of Psychiatry and Behavioral Sciences at Stanford University, and a consultation liaison psychiatrist at Palo Alto Veterans Affairs. As the director of the Translational Therapeutics Lab and associate professor in the Department of Psychiatry and Behavioral Sciences, Dr. Rodriguez leads studies investigating the brain basis of severe mental disorders, Her landmark clinical trials pioneer rapid-acting treatments for illnesses, including obsessive-compulsive disorder and post-traumatic stress disorder. Her NIH Foundation and donor-funded mechanistic and clinical efficacy studies span target glutamatergic, you're welcome, I said that, and an opioid pathway pharmacotherapy, non-invasive brain stimulation, and psychotherapy for OCD, PSD, and hoarding disorder. Dr. Rodriguez also serves as deputy editor of the American Journal of Psychiatry, member of the Research Council of the American Psychiatric Association, member of Brain and Behavioral Research Foundation Scientific Council, and the Scientific and Clinical Advisory Board of the International OCD Foundation. She's won several national awards, including the Presidential Early Career Award for Scientists and Engineers. Carolyn's work has been highlighted in numerous publications. That's the one part I should have made shorter because I didn't name all the publications. I just said all the publications. Yeah, we're good. She contributes articles to Harvard Business Review and Huffington Post. Carolyn received her BS in Computer Sciences from Harvard University, followed by an MD from Harvard and a PhD in Neuroscience and Genetics from Harvard. And she is born in San Juan. She lives in with her husband and 3 children in Palo Alto. Basically, she has a boring life. Hi, Carolyn. Thank you for joining us.
Thank you. Thank you for inviting me.
So excited to see you and have you and hear your expertise. Hi, Margaret. Good to see you. Next, we have Dr. Elizabeth McInvale, PhD, is the director of the McLean Houston OCD program. She was the founder of the Peace of Mind Foundation, now a part of the International OCD Foundation, and helped run OCDchallenge.org, a self-help website for OCD. Elizabeth was the first ever national spokesperson for the IOCDF, where she now serves as a board member. She was diagnosed with OCD at age 12 and underwent both inpatient and outpatient therapy. Elizabeth engages in clinical work, research, and advocacy with the goal of improving access to care and OCD treatment. Her life goal is to make a difference in the lives of those with OCD. I'd say you've achieved your life goal. You need a new life goal. You're always, well, I mean, I'm just saying you're making a big difference already. Hi, Liz. It's so good to have you.
Thank you, Ethan. Nice to be here. Excited to join you and everybody. I echo Ethan's sentiments earlier that I hope the conference was amazing, and looking forward to today.
Absolutely. Thank you, Liz. A brief thing. I am wearing an OCD shirt. They need to print them higher because otherwise it looks like I threw on like a white tee, but it is an OCD Awareness shirt. Liz is wondering why she didn't get that shirt either. If you were on, yeah, she's upset that she didn't get the swag. That's 2 pieces of swag she didn't get.
Both times this week. Yeah, Ethan gets it. I don't. Just saying
words,
that.
Liz,
I mean, if you're listening.
Liz, try harder. Just try harder. Next up, we have Stephen Smith. Stephen Smith is the co-founder and chief executive officer of NoCD, the largest telehealth provider focused exclusively on ending the suffering caused by OCD worldwide. After emerging from a personal struggle with undiagnosed OCD and experiencing exposure and response prevention, ERP therapy, success firsthand, Stephen made it his mission to transform the behavioral health treatment system. The goal: create an anytime, anywhere virtual care platform that lets people get diagnosed quickly and accurately and treated appropriately using ERP therapy, considered the gold standard in OCD treatment. The result is NoCD, the world's largest OCD patient community, and now the #1 telehealth provider for ERP therapy. Thanks, Stephen, for being here.
Thank you all for having us, and thanks for all the other panelists here too. We're really excited to talk today about the future of OCD treatment.
Awesome. And certainly last but not least, we have Dr. Wayne Goodman, professor and chair of the Menninger Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine, specializes in OCD, obsessive compulsive disorder, and deep brain stimulation, DBS, for intractable psychiatric illnesses. He is the principal developer of the Yale Brown Obsessive Compulsive Scale, or YBOX, the gold standard for assessing OCD, and co-founder of the International OCD Foundation, the major advocacy group for patients in OCD. We know the IOCDF well. Thank you, Wayne, we wouldn't be here if it weren't for you. So, thank you. And co-founder of the major advocacy group for patients with OCD. Okay. Prior to joining Baylor, he held senior administrative positions at Mount Sinai Hospital in New York, NIMH, and the University of Florida. He graduated from Columbia University with a degree in electrical engineering, received his medical degree from Boston University School of Medicine, and completed his internship, residency, and research fellowship at Yale School of Medicine, where he remained on faculty for 7 years. He's currently a principal investigator on grants from NIH's Brain Initiative, including one on developing adaptive DBS for OCD. Thank you, Wayne, for having us. Thank you, Wayne, for being here.
Thank you, Ethan. And I'm joined by fruit flies tonight, so if you see me swatting, you'll know why.
That is true. We are aware that Wayne has a fruit fly infestation, and they are currently attacking him as we speak. So if you are triggered, just get off now. Okay. So,
I'm not kidding.
Or if you have, no, he's not kidding. So if you have questions for fruit flies, please let us know, and we'll pass them on from Wayne to said fruit fly. All right. So first of all, thank you for joining this roundtable. In all seriousness, I'm super excited for this. You know, it's so important for a couple of reasons. And I promise to everyone watching, it will not be Ethan speaking the whole time. I know it feels like that, and that can be a scary thing. So I apologize. But it is so crucial for individuals, that is you all and some of us with OCD and related disorders, to know that brilliant minds are working diligently on their behalf. I think that is so crucial to solve this crisis, and it is a crisis. Stephen makes no qualms about OCD being a crisis, to show the world and other researchers that this needs to be studied more, and it is worth studying because the number of cases of individuals with OCD, as we know, is underreported. It's a bigger systemic issues than the powers that be think, and it's also important to acknowledge incredible movement we're seeing in a variety of areas related to OCD, both in education, stigma reduction, and treatment. Basically, change is happening. It's happening in a big way, not only with how do we reach individuals with OCD, but how we can treat them. And so that is what we are here to discuss today. And I hope you're excited. Please put your questions in the comments. If you have them, we will try to get to them, but we have a lot to cover in this short hour and a half. First of all, I want to go around to each of you and sort of just give us a brief overview. I know I read it in your bios, but currently, let's start with what you do in layman's terms, and why you're interested in working researching OCD. Let's start with Carolyn.
Yeah. So for me, I think, I just springboarding on a hearing about Stephen's frustration in his journey to get treatment. And then hopefully, Stephen, you will share a little bit more about that with us today. From, he and I have talked about from the perspective of being a psychiatrist, it is incredibly frustrating to see patients who have tried first line treatments and it hasn't been helpful for them. And we don't know ahead of time what treatment will be helpful. And so, currently there's a trial and error process for medications. And another thing that's incredibly frustrating is how long it can take for some people, even with first line treatments, to get better. So with pharmacology or drugs, it can take 2 to 3 months. And also with cognitive behavioral therapy and exposure and response prevention, it can also take 2 to 3 months. And so my work really sprang from that frustration, which is how can we get people better faster? And seeing what was out there, for every 11 drugs being studied in cancer and 8 drugs being studied in neurology, only 1 is being studied in psychiatry. And I felt like that there was just this big chasm in terms of new and cutting edge treatments. And we haven't had a new medication treatment in OCD since the 1990s. So I really embarked on a journey of looking at drugs that act on the glutamate systems, the main excitatory messenger in the brain. And at the time, in the field, there were a lot of medications that altered this modulator. And then also looking at some basic research, looking at a scaffolding protein, and when it's disrupted in animal models, they have repetitive grooming. That when you reintroduce that protein, they stop this grooming. So all these kind of working evidence suggests that glutamate might be important. And so I tested ketamine, a drug that had at the time been very intriguing in depression, initially at Yale and then replicated in NIH, showing rapid reduction of OCD. And we did a small pilot study showing that a single infusion of ketamine could rapidly decrease OCD symptoms in all the participants. And then half of individuals that got ketamine went on to continue to have these anti-obsessional effects at 1 week. And so we've been since working on that, and I'm happy to share more, but that's how I got interested in it.
I love that. Thank you so much, Carolyn. Yeah, and Don wrote, I feel like we need more than SSRIs to treat OCD. Some of us don't respond to them and can't tolerate the side effects. Thank you, Fran. Of clomipramine, I have had DTMS and tried ketamine as well. It would be great to find something that actually makes a difference, not cures OCD, but actually moves the needle a bit. So to your point, Carolyn. Wayne, we will get into your work, but I also like to make this as personal as possible for those people that may not know who everyone is. And so for those of you that may not know Wayne from his bio, he is, not to age you, at 42 currently, but your work, I won't read Liz's face right now, but your work is precedes you, and you have paved a large path for so many to walk down and through, and you continue at it to carve your niche. I'm super curious, from the Y Box, founding the IOCDF, at the time the OCD Foundation, all the way to your work now. How did you land on OCD?
The truth? You want to know the truth, huh? So I knew when I entered the field of psychiatry, I wanted to do research, and I did that at Yale. And OCD was the only anxiety disorder that wasn't attached to another faculty member. So I decided to. It was an open area, and it turned out to be, a wonderful opportunity. I wound up being at a time when, before OCD was a household word, and it was also around the time that there were new observations about SRIs and clomipramine being effective in OCD. So throughout my career, I've been interested in both treating OCD and understanding its biology. And in the first half of my career, mostly focused on medications. And part of that time was trying to infer the biology, what caused OCD, by learning something about the mechanism of action of treatment. And that really has led nowhere, at least led me nowhere. We still have, the same, as Carolyn mentioned, we still have the same medications mostly as our first line treatment. We haven't figured out, what the role is of serotonin in OCD. So at some point, I transitioned. I looked at a lot of other medications. I transitioned to the role of medical devices for treatment-resistant OCD, and that's largely what I focus on now.
That's a great segue into what you're focusing on now. So give us a little insight into the things that you specialize in your research, and then we'll dive deeper into that.
So this is only for the most severe cases of OCD, that have not responded to other treatments. And before we got on, you made Ethan, you mentioned a quote by Vlad Korik that was really important, is that the only reason we call the illnesses, treatment resistant is because our science hasn't caught up. So given that caveat, still I see patients that have failed ERP in the best of hands, and multiple medications and TMS, and so I work with neurosurgeons, and the neurosurgeon implants electrode in the part of the brain that we think might help OCD. And then my job in the coming months is to program that device and tune it to see whether I can improve the symptoms of OCD. And when it works very well. It's not a cure. That was mentioned in the last quote. I don't like that word cure. I think it's a jinx. I think it invites OCD when people think they're cured. It invites it. It's like a challenge. So I don't like. I wish we had a cure. I certainly strive for remission. But when the DBS works, it can work very effectively and be life changing. And it's extremely gratifying for me to see that.
That's amazing, and I really want to hear more about that. Just in our talks previously, when you've just mentioned, tuning on using an iPad, and different tablets, just like the idea of control, it's mind-boggling. And so I look forward to discussing it more. So thank you, Wayne. Stephen, I remember. This is where advocates, we and Liz and Stephen and I, as individuals with OCD, talk about this as we wouldn't change what's happened because we are where we're supposed to be. And I wouldn't be having this conversation with any of you had I not gone through my own journey. And I feel very blessed and grateful to call you all friends and to be here tonight. And, you know, Stephen is no different. We met in 2013 or 2014 at a restaurant in Pasadena. He's like, I have an idea. And we got burger. It was Slater's 50-50, which is like half bacon, half beef, very healthy. And
the mac and
he said,
cheese
I
balls.
have an idea. What? And mac and cheese balls. That's right.
There you go.
Well, and he's like, I have an idea for an app I want to run by you. And you know, that's how we met. So Stephen, just quickly, I know we're talking about the past, but it's important to know what came before to get to where we got. So a little bit about, you know, how you found OCD, where you came from.
Sure. Well, first of all, thanks again for having me. To your point, like OCD is very challenging, but when you go through it and you manage it, and, you know, you can not only live your life, but also meet a lot of other people who have gone through similar experiences. And some of the best friends I personally have are from the OCD community. So, and so it's great to be here with, I know, obviously Dr. Rodriguez and Dr. Goodman, as well as Dr. McInvale and you, Ethan, as well. So again, it's been a nice journey in the sense of very challenging, of course, going through OCD and the ringer that comes with trying to find treatment and then finally get to it and pay for it, et cetera. But it's really great to at least be in a position where you can connect with others, right? So I personally have OCD. I was one of the people that was misdiagnosed quite a bit. You know, I was told I had generalized anxiety disorder several times, eventually became depressed, and I was told I have depression. No one really identified the root problem that I was going through OCD. I had intrusive thoughts. They were taboo in nature. Did a lot of mental compulsions, and was just, you know, at one point housebound. I couldn't do anything, right? I had to leave school. I stopped going to college and had to, you know, stop playing football. I played football at a very small school down in Texas. And it was just kind of a really challenging experience. And one day, you know, I was desperate, and I was searching my intrusive thoughts online, trying to find answers, right? And many people do that as a compulsion. I was doing that as a compulsion. And but when I was searching my thoughts, I started to stumble upon people who were literally going through the same thing as me, and they defined their symptoms as OCD. And I was kind of scratching my head because I had no idea about OCD, right? I thought it was a personality quirk. And as I learned more, I realized like it was exactly what I was having. I had a subtype of, you know, the intrusive thoughts, and I was doing rituals that were mental primarily. I would analyze my thoughts, try to make them go away that way, and would you know, check my just set different senses. I would go and I would ask my family members for reassurance. I'd mentally reassure myself. So doing all the hallmark compulsions. And then I started to search for treatment. I was like, well, I don't really want to live with this, right? Where can I go get treatment? And I realized it's chronic. So you can't, as Dr. Goodman said, cure it, but you can manage it and live a really happy life while managing OCD. And I realized that you first want to try to get exposure and response prevention therapy from a licensed therapist who is specially trained in it. So I was trying to search, and there was one in my area, and because I was in Texas in the San Antonio area at the time, and there weren't too many folks, and so was put on a wait list, and then eventually got off the wait list, saw the therapist, and she diagnosed me. It was a huge relief, but started me on treatment, and that's where I trying to do ERP therapy, and it was kind of a tough experience because a lot of the times when you're by yourself, that's when OCD strikes the worst, right? When you're, you know, walking down the grocery store aisle and boom, you're triggered, right? Then what do? You have to get into response prevention mode and learn to accept uncertainty in that moment. And that was really tough. And so, but nonetheless, got through therapy to the point where I was able to see reductions in severity myself. And therapy is, when I say get through therapy, I mean, I was able to get to that point. You have to become your own therapist eventually and learn how to self-manage. You know, but that was kind of where I was seeing progress, right? And then eventually went back to school, finished up my degree, and finished up playing sports in college, finished up my football career, and then was reflecting back, thinking, you know, how can we make this treatment just more accessible, right? It's very effective clinically, but operationally, it's hard to get to treatment, and then once you're in treatment, it's hard just to stay in it. So, is there a way to make it easier, right? And is there a way that we can use technology to kind of be the bridge between getting identified and then managing OCD? And then can we also use technology to help, you know, really train and supervise licensed therapists who are interested in developing expertise in OCD? And so, yeah, that's kind of what we've done at OCD, right? we're focused on just helping people. And like many people here on this panel, we want what's best for the OCD community, right? And we want to make sure people can get treatment easily. So yeah, so that's kind of my background and just a person with the condition. But you know, I've been fortunate enough to work with so many amazing people here. So that's been one of the nice parts about an OCD. You always collaborate with people who are like-minded and passionate.
Thank you, Stephen. Appreciate that. And important for all of you watching, after we get through this, I promise I really want to dive into the future stuff and try to get through as many topics as possible. But great conversation in the chat thread. Really appreciate it. A lot of conversation on glutamate, which maybe we can have Carolyn and Wayne kind of weigh in on. Liz, your story as an advocate or your story of OCD is well known as a sort of the first face of IOCDF and a spokesperson at that. My question to you, and feel free to talk as little or as much about your past with OCD as you want, but I'm extremely curious why you could have stopped as an advocate at 17, 18. Why was it so important for you to go into the clinical side, and what is your goal as a clinician now?
Yeah, it's a great question. And I think that the work that we love, the work that we do calls us. I don't think that it chooses us. We don't really choose it. And I think that advocacy wasn't something I was planning to do. I kind of got thrown into it, and it happened to work out the way that it did. And what I learned is that advocacy is my passion. It's my opportunity to destigmatize mental health and hopefully make a difference in the way we understand and talk about OCD. As Wayne and many others mentioned, like OCD as an acronym wasn't understood when I first sought treatment. No one knew what OCD was. I remember when someone gave me that diagnosis, my mom was like, "What's OCD?" I don't think we have that problem anymore. It doesn't mean that we don't understand OCD appropriately, right? We still have a lot of room to grow, but there has been progress, and the opportunity to continue that will call me for the rest of my life, and will be a calling I'll continue to act on. As far as moving into treatment, I think much like Stephen and others have shared, it wasn't my plan. When I was young, I never would have thought I'd be a clinician, and that was something I was interested in doing. But when you go through what you've gone through and you realize that my ability to seek ERP treatment and to manage my symptoms, that should be the norm. That shouldn't be an exception. And I realize, like Stephen and others, right, we talk about it, that like those of us that have been through it, we want to do anything we can to give other people the chance to manage their symptoms. And we all do it differently, right? In our paths to our ability to treat or to serve or to advocate, right? It looks different. But at the end of the day, how could I stop when there's so much work to do? And so, for me, my goal is that effective treatment is the norm and is accessible by anyone, anywhere. And we are all working on that in different ways. I obviously now am at an intensive treatment program, and the way that I try to work on it is how can we treat the most severe and those that aren't going to benefit as much from outpatient but need a really high level of care in a behavioral approach. And that's been my passion, and one of the ways clinically I want to continue to improve the services that we offer. But to answer your question, sorry it was so long, is I don't think I chose it. I think it chose me, and I think it continues to every day as I continue to have the opportunity, which is what I view it as, to serve our patients.
Thank you, Liz. That's beautifully said. I'm going to stay with you a second.
That's scary.
We don't have to. We can go back to Wayne's fruit flies if you want. So, you're a behavioral therapist. You're the clinical director at McLean Houston. But at the end of the day, you're an individual with OCD, as you said, and a clinician. And for me, my question to you is, what is the future of ERP? What is the future of the gold standard of treatment? And the reason I ask that is there somewhere to take it? Does it have room to grow? Is there a new way of exploring ERP as a modality of treatment as the gold standard and improving upon it?
Totally. This is my passion right now. This is my passion always, but it's really been ignited lately as I've been on the ground doing the work that I do for the past couple years. But more importantly, like, and I want to challenge Stephen and those of us, Ethan, that are advocates and individuals who live with OCD to think about what were our turning points and when did we shift from suffering to managing. And what took that, right? I think that when I first started advocacy, candidly, I understood my acceptance of OCD, meaning that I had to accept a life of suffering. And I would have told people very openly and candidly that, like, I live with OCD, which means I'm always going to struggle. I'm always going to be battling it. And like every day I'm just like in the ring, putting my gloves on. And what I've learned over the past, recent years in particular, it took me a long time, is that that doesn't have to be the case. Just because you have a diagnosis of OCD, it doesn't actually mean that it always has to be a struggle or that it always has to be a battle, and that you can have freedom. And people might say, well, what was that? And for me, it's the way it's the way I understand and the way I implement ERP into my life every day. So ERP doesn't have to happen in a vacuum for every symptom. ERP is about us accepting uncertainty and the entire principles and concepts of the treatment for our life. A lot of us with OCD talk about it being this like constant game of whack-a-mole where it's one symptom comes up and we're addressing it with ERP and the next symptom comes up and we're addressing it with ERP. And that's frankly like fucking exhausting. Sorry, everyone knows I never cuss, so I apologize. Ethan's face.
Wow.
But it is.
You don't know how amazing this is. Go ahead, Liz.
Sorry. But it is like it's absolutely exhausting and tiring. And you spend your life and your days like constantly fighting and pushing against symptoms. And I think a lot of us accept that that's what ERP means. And like effective ERP is just like constantly battling these symptoms. When the reality is that it might be like we have to learn how to use ERP through our current symptoms, but are we buying into the concept? And I actually believe that it should be ERP plus uncertainty, not ERP. Because I can do ERP for specific triggers, but if I don't accept the concept of uncertainty, I'm going to end up white knuckling it. And so I think we have so much room to grow. And I think we continue to learn every single day. One thing I learned from Dr. Goodman and my work with him is that a lot of patients would come to us who would be needing DBS. And we would hear patients say, this is my last resort. And Wayne always challenged that. And I use that every day, Dr. Goodman, because I believe that nothing is a last resort. Treatment can always be augmented. And ERP, like we don't need to accept what ERP is right now as the best we're ever going to get, right? We should always be thinking about how can ERP be improved operationally on the floor from a behavioral intervention? How can treatment and the way people access it, like the work Stephen's doing, be improved? And how can medications be improved? So ERP is just starting. I think we've begun to scratch the surface. We have an effective, amazing intervention. But as you know, and every clinician on here knows, we can administer ERP, but the person who administers it and the way and the approach that they administer it significantly changes the treatment outcomes for that individual. And that is something we need to improve. We need to improve the way we standardize it, the way we operationalize it, and the way we understand it as behavioralists.
Mm-hmm.
I love that, Liz. We haven't talked about that particular subject, but I've always thought to myself that when I got better and I looked at this idea of uncertainty, the analogy that I used is or the metaphor I should say is I always pictured wrapping myself in what I called the uncertainty blanket, which is like just completely wrapped in this blanket of uncertainty where it wasn't just about the OCD symptomatology, it was about my life. And if I embrace this idea of uncertainty, as you said, throughout the whole life, then, I'm prepared not only for OCD, but for life. And I've said this before in live streams that uncertainty can be exciting. I mean, uncertainty is hope. Uncertainty is what's around the corner, and the potential that comes with it. Like just everything, there's a yin and a yang to everything. And uncertainty is the same. So as much as we can be nervous or apprehensive or scared about what's next, that's also a reason to be really excited about it. Carolyn and Stephen, hang tight. I haven't forgotten about you. Dr. Goodman, DBS, you mentioned briefly a little bit about what it is. What are the advancements that you're starting to make in DBS in terms of the efficacy, the way you execute it, patient interaction with it, how they're doing? What are you seeing overall in the DBS process? And just quickly, for those that may have just tuned in, super quickly, just define again what it is.
Yeah, I should. So, when people first hear about deep brain stimulation and they hear that it's brain surgery, it's very frightening, and I understand that. But if you had a parent, let's say, or you yourself had Parkinson's disease, and you had failed the usual medications, and you reached a point where it was difficult for you to get up out of a chair, it was difficult for you to ambulate and take care of your everyday functions, and somebody said, well, we have this treatment called deep brain stimulation that may be life-changing for you. Not that it's got risks. Anytime you have surgery, you got risks, including brain surgery, but you might greet it differently. You might see it differently. And so that's how I see DBS for OCD. OCD, like Parkinson's, is a brain disorder. We don't know quite as much about it as we do about Parkinson's disease. We still may not be in the best place in the brain, but we found, and there are different choices. And so one of the things that I'm trying to do in my research, and so are others, are trying to figure out what is the circuit that underlies the symptoms of OCD, and how can we modulate that circuit. And there are different ways of doing that. Some of them have already been mentioned. They have nothing to do with surgery. They have nothing to do with drugs. So the way I've started to think about OCD is as a circuit disorder, that whether it's ERP or drugs, they may be acting at different nodes or different points in that circuit. And deep brain stimulation would pick something that seems to be very robust. That and try to answer your question now. Not everybody gets better. We probably response rates are about I'd say 65%, like 2/3 of patients get significantly better. I would wish it were 100%, and that would be our goal. And it takes a while for me to do the programming. And there are some risks associated with even if you go through the surgery, everything is fine, and generally is. But when I'm doing the programming, there could be behavioral side effects, and one of them is something called hypomania. And when I tell patients I may make you too happy, they say, "Oh, that doesn't sound like a problem." But along with that, also can be some changes in judgment, risk taking. It's sort of the opposite of OCD, and that can get you into some trouble. So what we've been doing is we've been funded by the National Institute of Health to try to develop a DBS system that can automatically detect when somebody's either needs more or less stimulation. And so that's one of the things we've been working on. I think that partially answers your question, but in terms of the future question, I don't see, it's not my goal in life is to greatly expand the use of surgery for OCD. I think it's probably underutilized. I think there are probably patients out there who haven't heard of it and might benefit from it. But really my goal is to understand more about those circuits so we can find other tools, other treatments that don't require surgery that can be just as effective.
And can I point out,
just think it's
Dr. Goodman,
go ahead, Liz.
Sorry, Ethan, but like you're talking about efficacy rates of 60 to 65% of people who fail traditional treatment, right? Like that's really important too, is I think that we don't want to just look at this overall rate, but we're talking about individuals who haven't had success with traditional treatment. That's actually really high.
Thank you, Liz. Yeah, no, that's a great way. You're talking about a cohort within a cohort, and that's important to note. And I actually, Wayne, I love how things come together for people in life and where they utilize other skills and tools. And like, who would have thought when you were in mechanical engineering that the circuits you'd be studying would be what? Electrical engineering. Sorry. Yes. Sorry. But regardless, who would have thought you'd be studying the electrical impulses of the brain? And I think that's really cool how that all
I still remember
correlates.
Ohm's law. That's the only thing I remember from engineering school.
Well, stay tuned for part 2 on Ohm's law. No, but I think it's cool how everything gels. Thank you, Wayne. And just to point out, so you're basically talking about utilizing AI learning to determine how much to back off or back on.
Yes.
Within. That's amazing.
And so I'm working with engineers that were trained in this century, and who are trying to decode. So one of the things that we've done that's really cool, and you saw some of this, Liz, when you were working here, but now we've done more of ERP at home in some of our patients. At the same time, we're recording from their brains the electrical signals. So we're trying. The engineers are trying to decipher the relationship between what we're recording from the brain and what's happening at home, either when their OCD is better or worse, or actually right during ERP.
Wow, that's really amazing, Carolyn. I know your lab is known. I feel like, anyway, I'll let you speak, but you are doing a bunch of really cool things. People mentioned ketamine. Why are you? I don't want to say far out, because they're not. But I think when people, I know for me, I don't want to speak for other people. When I first heard some of the things you were doing, I was like, whoa, that's interesting. And who would have thought of that? So talk about some of the things that you're doing, or maybe some recent studies that you've done that show potential, and how you land on some of these specific trials.
Yeah, happy to. And I want to circle back to the point Wayne was making, which is he's talking about the circuit level, and a lot of the drugs that we're talking about, can conceptualize them at the molecular level of the receptor level. And we need people who are working on all these different levels, because at the end of the day, we currently don't know how obsessions and compulsions are encoded in the brain. And Wayne has been talking very beautifully about decoding those signals and trying to understand. And so, I think all different levels of approaches are needed. We know that not one size fits all. And I think, it's important, as Stephen is saying, is like, how do we get out there? How do we reach as many people as possible? And Liz is saying that we need to, some people don't want to try medications, and exposure and response prevention is a gold standard. So how do we innovate and build from there? So we really need all these approaches so that individuals have as much choice as possible. At the same time, each of these approaches leads us down to understanding and peeling back the layers more about how OCD is generated in the brain. And ultimately, when we unearth this, will be able to get more to a precision medicine viewpoint, which is, you see this in cancer research, which is like, how do you see what subtypes that an individual has, and then how do you tailor the treatment toward it? And for the ketamine work that we're doing, we just finished a larger study funded by NIMH, that it's incorporating markers to look at changes in glutamate and GABA and other neurotransmitters, circuit-based measures looking at cognitive control, as well as EEG. And the hope is that, if ketamine is helping about half of individuals, can you actually then start to look at what are some of the differences in the brain between people who respond and not? And can that be sort of inroads that can help us understand the ultimate question, which is, how do we decide which treatment is best for which person, and how do we deliver it at the right time when they need it? And the work, I've been fortunate to be funded by the International OCD Foundation to look at metabolite of ketamine called RRH&K. So Carlos Zarate has developed this at NIH, and it's been shown by Todd Gould and others in animal models that potentially this could have rapid effects like ketamine, but in depression, but potentially have less of the side effects. And that's one thing as a clinician, seeing folks that have nausea or vomiting or increased blood pressure, that is a caution, right, in terms of this kind of medication. So that's one future direction. And the other is recent funding by the Foundation for OCD Research to look at MDMA for OCD. Really thinking about, as Liz was saying, how do we sort of innovate exposure and response prevention? And there's a barrier for some people in terms of being able to access these kinds of treatments. And MDMA is known for kind of pro-social empathy, has some effects on extinction learning. And is there potential to see if the combination of these two together could boost some of the benefits? I'm at the same time, Wayne may know this already, I'm very agnostic, and I like having equipoise in studies. So I don't, I think the answer is just as interesting if it doesn't help. And then we can say, hey, maybe you don't want to be trying MDMA. Why don't you just stick with like just ERP or try other approaches, right? And so the study, we really want to have like a really good control, and just are open to any result that could come out of it.
Yeah, you had told me you're doing a study on nitrous oxide
Mhm.
and OCD, and my question, go ahead.
Yes, for nitrous oxide. This sort of stemmed out of some work that we were doing from, as Stephen mentioned, that there was one point where he was really stuck at home, and it just really struck me that for people who can't even get out of the house to like get treatment, how do we help those people? And my daughter was suffering from an asthma attack, and she just took her inhaler, felt much better, could run outside and play. And I just kept thinking about that, like, how do we help people who are kind of stuck at home? We tried an intranasal ketamine study, but it was incredibly difficult to recruit for. A lot of people with contamination, OCD, didn't want to have something in their nose, and then also they didn't like it in just all the people who came in. They just didn't like having something in their nose, and they were like, could I get this any other way? Is there like IV or something else? And so, part of doing clinical trials is testing feasibility, and at least in our hands, it didn't seem like that was the best direction to go. But nitrous oxide is a works through the glutamate system, also works through the opioid system, which is there's some research that maybe some of ketamine's effects are potentially this combination of two systems that are activated. And it's laughing gas. You can get it at the dental office. In the military, this gas is used for pain in the field. And we wanted to test it to see if it's something that could be helpful for OCD. Very rapid on, rapid off. You don't have some of the trouble with ketamine where you can't drive for 24 hours. Very well tolerated.
Thank you. And Felice,
Were you raising your hand, or was that a fruit fly?
It's a fruit fly.
No,
and Ethan's got them now too.
No, I swear it was a little gnat or a fly, and I thought they went from Wayne to me. I'm not even kidding. That's why I don't know what it is, but it's gone through my Ethernet. So who knows? And Felice, it's funny because right when I asked you, Carolyn, about nitrous, Felice Becker was reading today about your nitrous oxide research, and then she wrote, I beat you to the punch, Ethan. Yes, you did, Felice. And by the way, we will talk about MDMA. We will talk about glutamate because a lot of people have questions about glutamate, also some TMS questions as well. Stephen, thank you for being so patient. So this is what I love about this group of individuals is that, with Wayne and Carolyn, we've talked about technology and the way, technology can be used to find treatments for OCD. Of course, Liz, we've talked about, a little bit about exposure response prevention and, her hopes for the future of where that treatment goes. Everything bridges to you, my man. I don't normally talk like that. That's super weird that I said that, but whatever. But here's what's interesting is like you've now taken technology and you're using technology to connect individuals with OCD with treatment. And I told Liz I guess Liz was carried away by a fruit fly. She'll be back shortly, I'm sure. Wayne has targeted them for assassination. Way to go. But Stephen, for me, what are you doing that's so innovative? What do you see? Why have you seen this as necessary? You touched on that before. And where do you see this going?
This being exactly just the future of treatment?
No CD, teletherapy, how you're integrating more importantly, how have you integrated what are you doing differently and new? Have you taken telehealth that's worked and applied it to OCD?
Sure.
What are you doing that's innovative and new? Talk to that.
I'll just kind of describe first what we do, and then I'll try to describe like what we're hoping to do too going forward. So what we do is we offer ERP therapy online. People can come into the NoCD platform either on their desktop or on their phone. They can do live face-to-face sessions with licensed therapists that have specialty training and exposure response prevention from our network. And then between sessions, when the therapist isn't available, people can access support from different self-help tools, different peer communities. And, the goal is that you never are really alone, right? And that's our big objective. And, on the back end, what we do, first of all, we aggregate a community, right? We help people realize what they're going through, especially if they're too embarrassed to kind of come forward and talk about some of the symptoms, given OCD is kind of challenging to talk about at times, especially some of the more taboo subtypes. And we create content and community that fosters trust, that helps to inform people where to go. And then from there, we go and we help encourage people to learn about treatment, take their steps into treatment, and hopefully, connect to a licensed therapist that specializes in OCD and ERP. And that's our goal, right? We know that's the first line. And if we can make that more accessible, then we've really effectively helped the masses. And so we train licensed therapists on the back end. We train hundreds of therapists a month now to basically learn how to do exposure and response prevention. And then we actively supervise them using our clinical leadership team's expertise, using data science. We make sure that people can not only learn, or providers not only can learn how to do treatment but also they can then learn continuously, knowing that's incredibly important. So we have an amazing chief clinical officer, Dr. Patrick McGrath, who spearheads a lot of the training and the management of our network. And we also have Dr. Jamie Fiesner, who's been helpful in helping us design, basically treatment that we offer, right? And that kind of leads to where we're going, right? Our goal is to make ERP more efficient. So we know it's really effective, but can we make it more efficient so that ultimately more people can access it, right? So our goal is just to make sure that treatment can be more and more efficient, and we're developing protocols that are personalized for specific people that can help make sure that they can get better as quickly as possible and then maintain the results as long as possible. And I'm going to address one of the points here from before is, do we hear from different advocates who are currently suffering? And I would say, OCD ebbs and flows, right? So it's never always, roses and daisies. That's why I tell people when I talk about OCD, there are moments where it ebbs, right? You'll have, days or sometimes weeks where you're starting to notice that OCD is a little bit more intense and you feel anxious, right? And then it's at that point, though, the goal is, can you have the skill set and tools needed to learn how to accept uncertainty? And what does that even mean? For me, at least, that was kind of just, letting, almost surrendering to the fight, right? I would consistently in my head fight OCD. I would fight the intrusive thoughts, try to disprove them. And at a certain point, I'm like, you know what? Maybe that could happen. Who knows? And I'm just going to let whatever happens. And when I stopped caring as much, that's when I noticed I accepted the uncertainty more, and I just naturally, continued on with my day without having as much distress, and eventually, was kind of back into the groove of things. So for me personally, it ebbs and flows like everyone else with the condition, but once you can manage it, the ebbing happens less frequently. And so that's, for me, at least my experience. I know others have said something similar, but that's the goal. I mean, it's you want to be able to get to a point where you can get to treatment, you can learn how to get better, you see getting better as in you've seen reductions in severity, you can start to regain your life, and then how do you stay better, right? How do you maintain your progress? And that's through just, again, keeping up with the treatment. What we're hoping to do, and this is something that I haven't talked about much yet publicly, but I would love to do so here. We're starting to integrate IOP and PHP services. We're starting to integrate telepsychiatric services. And the goal is eventually, people can access care. They could get to different levels of care depending on what they need. We have so far over 1 in 3 Americans with OCD who can access, ERP therapy through their insurance through an OCD right now. That's going to be about 1 in 2 by the end of this year. And then next year, we're beginning to offer, we're looking to partner more within Medicaid and Medicare, so we can ultimately get more folks who are from underserved communities that can get treatment too. So that's a big goal of ours, right? We want to make sure that we can kind of connect the dots in the OCD community, given that there's been a lot of fragmentation over the years, and it's prevented people from getting treatment that they need effectively. And so we're just trying to make it easier for everyone. So for people with the condition, for providers who are interested in serving the OCD community, as well as for researchers who want to make advancements to this the whole OCD treatment ecosystem, right? And so we also help augment clinical trial recruitment, make it easier for people to connect to to different clinical trials if they're interested and they've maybe failed ERP or other SSRI medications in the past. So that's a big objective for us too, so we can keep advancing treatment. And yeah, we're just, again, for a group of people who are passionate about helping the OCD community get the treatments that people need.
Thank you, Stephen. Stay on you for one more second.
Sure.
Keep it short, man. Also, some great questions for you. But I'm just going to tell everyone we'll give an email address out at the end. Any questions you have, send them your way. We'll make sure to get them to Carolyn, Wayne, Liz, or Stephen, and get your questions answered if we don't have time at the end. Stephen, the other things that you've done, and this is, I consider a future of treatment, is that you were able to do something that on a national scale that not many people have been able to do, and that is you were able to get into the room with the insurance providers and make them see that OCD was a problem. While it doesn't sound technologically advanced, it's a massive advancement for the field, especially in the realm of what you're doing. Just I know at the end of the day, it came from passion, but talk to me a little bit about what you did to make them see that it was a serious problem.
Sure. It's great. Yeah, I appreciate you bringing that up. It was a very exhausting effort. I was a guy that just kept knocking on their door and wouldn't go away until they at least answered it. And then they slammed it in my face a few times. I kept coming back. I mean, our team did the same. So, but I'll kind of explain to you what we really did. We just basically showed these different insurers, thanks to the data that people offered when we asked, like, hey, would you be interested in sharing who's your health insurance provider? We'd go to these different insurers and say, look, you have thousands of people today who are suffering with this condition, and everyone wants to get access to exposure response prevention therapy, but it's not in network. And what are you going to do about it, right? The problem is, if people don't get access to this as a first line intervention, data show that their life is potentially going to get worse because they're going to see a talk therapist that might actually teach them to do compulsions, right? And we see that all the time. I mean, I personally experienced it. I mean, most people I talk to first see providers who don't specialize in OCD, and then unfortunately they go through the ringer with them. And we at first, payers would say, no, OCD is not an issue, right? It's not a prevalent issue. Maybe a handful of people in our entire population suffer with this. And so we started asking, like, well, why are payers saying that? And we realized it's because of the misdiagnosis issue, right? So what happens is, when you go to a therapist or you go to any type of provider, you will get a claim submitted back to the insurance company, right? So your provider will say you have, for example, anxiety, and they tell the insurance company through a different code that you have anxiety. So what happens at scale is the insurance company looks at their data and they say, wow, we have a lot of people with anxiety and we need to do something about it. So if you're misdiagnosed, what happens is false data gets sent back to the insurance company. And so what happens with the insurance companies is that they don't see actually OCD showing up in their data, and they don't see the prevalence of it then. And then they can't associate the cost of it going untreated back to OCD. They can't do that. So what we did is we just did a research study that showed 96% of the OCD community is actually misdiagnosed, or it doesn't show up in OCD payer claims. And we showed that per 1 million person population, $100 million is lost each year due to OCD going untreated. to these different insurers. And so we've been able to show via data what that looks like. And it's just been an exhaustive effort that has been possible because of our team. And we're passionate about this issue, right? We want this issue to be solved. And now I think what we started to show is that if you get access to ERP early on, not only can your OCD severity get reduced, but also so can your comorbidity severity, right? So your depression, anxiety, and stress will get reduced as well. And so what happens is you can see that oftentimes getting treatment to the root problem treats the whole person, especially with people with OCD. And again, we've shown this now with thousands and thousands of patients to these different insurance companies, and are starting to get it now. So we saw what happened was, we'd started off in several states, right? And many of the insurers said, well, this is working. I didn't realize it was such a big issue. Let's expand this nationally. Right. And so now we're national with many great partners, United Healthcare, Cigna. We're scaling nationally with Anthem Blue Cross. We're now in a handful of Anthem states. Kaiser Permanente is scaling us right now. We're so proud to be their partner. They also are getting behind the movement to expand ERP therapy. They participated in our most recent round of financing. And so they're starting to really see that there's ways to innovate here and really drive access to effective care for people with OCD, not just today, but also in the long term, which ties into the great work that many of the folks on this panel are doing, right? And yeah, so times are really changing here, which is exciting if you're someone with OCD. And I would bet by the next 2 years, no matter which state you live in, no matter how much money you make, you can at least get access to ERP therapy covered by your insurance. And
thank you, Stephen.
Sorry.
Go ahead. No, you're fine. Thank you very much, Stephen. I want to turn back to Liz, Wayne, and Carolyn. Thank you so much for hanging tight, because I have a bunch of psychiatrist questions coming up. So I want to speak to Liz real quick before we turn, because again, I want to talk about glutamate. There's some TMS questions, some ketamine questions, things like that. Liz, I have a question for you, and it's a question that I think many individuals probably hear, or an idea that I heard. When I went to residential, I was told that it was sort of my last chance. Like, that's where you go when you're the sickest. And in my head, it was immediately like, okay, well, if I don't succeed here, then I'm done. There's no other answers. I'm super curious. I don't know that who exactly, who and or what is residential for? What is the future of that look like? What place does residential treatment or intensive IOP exist with OCD? And I'm asking a number of questions, but I think I gave you enough to sort of talk off of.
No, I love it. I think that it's important for us to think about. And, I think the reality is that majority of patients with OCD can benefit from outpatient levels of care. That's just the reality. Majority of people live with moderate to severe, but can benefit from either traditional ERP in an outpatient setting, or maybe even intensive in an outpatient setting, and may not need the higher levels of care that include residential, like ours in Houston, or even future things like DBS and whatnot, as Wayne's talking about here. But it does exist. There's many of us. I know I'm a candidate myself, who I tried ERP on an outpatient level, and the level of severity that I had, I remember I lied on every question on the Y box that Dr. Jorgensen did, and I still scored a 38 out of 40, and I was thinking like I was totally minimizing my symptoms. My severity level and the disability that I had for my OCD probably wasn't going to move the needle, at least in a meaningful, time efficient way, on an outpatient basis. And so I needed a higher level of care, more intensive program. I think that residential grows every day, and it should. Nobody should enter a residential program and get the treatment that I entered in when I got inpatient treatment 15 years ago, right? And I've actually been talking to, I know I messaged Stephen about it, and their Chief Clinical Officer, Dr. McGrath, to really think about, are there ways we can integrate care, right? Care should not be fragmented. And there are plenty of our patients who all of our patients actually return to outpatient care. And there's plenty of patients that Stephen has that need a higher level of care than OCD might offer. And so how can we streamline care, right? We've seen in the past 15 years, the way electronic medical records have changed medical services and treatment and our understanding, right? You go to a doctor now, within a day, you can see your results on your own and you don't have to wait for that doctor to call you back. You go to a different hospital system and they can see your results from the last treatment you got at the last facility because of electronic medical records. And so I think the big piece for me that I would say is, what's the future of residential? It's continuing to shift the treatment that we provide. That'll happen through medical advances that we learn from those in the field. It'll happen as we continue to advance ERP. But I also want to push that all of us, and I'm talking to us on this panel too, it's our job to start to work together, right? And no, McLean Houston shouldn't work in isolation from NOCD, shouldn't work in isolation from BCM or from, Stanford. We should all be working together, so that, because we all know that together we can move the needle much, much further than any of us individually can. And so, can patients do residential readiness programs through NOCD? That's something I'm pitching, right? Is where are we going to do readiness? Like, what we have patients that need to do treatment to get ready for residential. And guess what? They need to have those established outpatient relationships so that when we discharge them, they're going back to someone they already know and trust versus starting over from step one. And I think that's the biggest disservice in the field that is a no-brainer. Like, how do we all always and start to work together and be collaborative instead of being anxious and being scared or feeling like we need to work in isolation or in silos, because that it's a disservice to our patients at the end of the day. And for those of us that have been a person in the system, it sucks to have to navigate it yourself. And it's much better if your providers can be navigating it together for you.
I love that. Thank you, Liz. That's so key and so crucial. And that's what's cool about all this. I think that, and I know I do this, which is we're those of us with OCD, we kind of not default, but kind of err on the side of black and white thinking and look at things. Well, that didn't work, so maybe this will work, and this will work, so maybe that will work. When in reality, we're looking at 4 individuals that represent 4 different things, but they all work synergistically. And that's what everybody's trying to say, is that, you can go to residential, you can get, you could, theoretically, you could, go to residential, not do as well, go to Wayne, get DBS, then be able to get ERP and accept it and take it in and do NOCD, and then go to Carol. I mean, it's like, it's all synergistic, and that's what's so cool. It's a holistic approach, utilizing as many tools that we have at our disposal. And that's what's really special about this group and ongoing conversations about this, is we all have the common goal. We're all coming at it from a different place, in your expertise, but at the end of the day, we're all meeting in the middle, which is, let's alleviate, this problem. Let's, on the way to a cure, if there's a cure, and that's a question down the road. So thank you, Liz. I love that. And you couldn't be more true. Number of questions on glutamate, on ketamine, and TMS efficacy. I'm going to turn to our psychiatrists on stream here. I know, Wayne, well, both of you have expertise in a variety of those subjects. So, and Wayne gets mad at me if I throw him hard questions.
I do.
So you do. You always give me crap about it. So let's talk first about glutamate. Effectiveness of glutamate, what the research has shown. I'll always talk about it. I've been on off-label glutamate medication since 2010 with Dr. Michael Janicki, put me on it at the OCDI. It was one of the few drugs that I honestly felt a difference. Out of all the SSRIs, I didn't see much difference, but I noticed a decrease in my racing thoughts when I went on this. So I'd love to hear your thoughts, first of all, on glutamate. Either one of you can start, please. I'm scared to call on Wayne.
Dr. Rodriguez. No. She knows more about this subject than I do.
Yeah, what I would say is, again, that, when you go through the OCD treatment algorithm, right? SSRI medications and cognitive behavioral therapy are your first lines, and about half of patients will be helped by those. And so, there are, and I think maybe this is the future of OCD, that it used to be that we only had a few different kind of options for augmentation strategies, but really the future of OCD is so hopeful. There's so many different new strategies and different new things to try. In the algorithm, you can augment if somebody's not having SSRI. Exposure and response prevention seems like it has the best evidence. There's also augmenting with antipsychotics. And then there's also glutamate medication that you can try. These are things like memantine. We didn't talk about this yet, but there's some studies out of Yale looking at riluzole as a glutamate modulator, and Biohaven now has a new study looking at troriluzole that potentially has less side effects than riluzole. And to disclose that I'm a site PI for one of those studies, and I also consult for them as well. And those kind of glutamate medications can be helpful for some people. We don't yet know. I think this is what I was saying before: is we don't know whom it will work for ahead of time, and that's what I find really exciting about studies where you can use a drug as a probe to really look at: are there ways that we can know ahead of time who will be helped by them? Right now, it's trial and error.
Trial and error is so frustrating, and I'm sure Stephen, I don't know, honestly, Stephen, if you were on medication was at one point, but I know I felt like a lab rat. I've had this conversation with Dr. Vlad Kurik, who Wayne mentioned. And I'm sure so many of you can relate to this idea of like, well, let's try this, let's go up, let's go down, let's titrate off. Nope, never mind, wasn't good enough. Let's get on the next thing. And you're like, oh my gosh, do you really know what you're doing? And it's the worst feeling in the world. So to that point, and then I'll move to Wayne, where is targeted medicine going? You talked a little bit about targeted therapy. I know there's some studies for targeted TMS and looking at, identifying regions of the brain so that it doesn't have to be so much trial and error. Are we looking at a future with targeted medication as well?
You're asking me?
Dr. Goodman.
Oh, yeah, we are. We are. So hopefully, the genetics may help. So, that may be one way of developing the kind of precision medicine approaches. But I thought, if you don't mind, I think, Ethan, you mentioned TMS. Is it okay if I describe
100%,
TMS?
yes. There's a lot of questions. There's a lot of questions on whether it's effective and
Sure.
it's actually effective.
So
it's FDA approved.
First, it's TMS stands for transcranial magnetic stimulation, and the particular type of TMS that's been shown effective for OCD is called deep TMS. It's by a company called Brainsway. They conducted clinical trials where they compared the active TMS with fake or sham TMS, and those studies were positive, and they were positive enough that the FDA cleared them for showing that it is effective in OCD. One of the questions that I think a lot of us have about, what you talked about, Dr. Rodriguez talked about, the algorithm. It's a little unclear when you step in with deep TMS. I think that's still being decided. It's probably not the first thing you try, although there's certainly patients that do try it first because, maybe they had ERP or they didn't like ERP. They don't want medications. And one of the advantages of TMS is it's non-invasive and it's very safe. One of the disadvantages, and this speaks to some of the things that Stephen has talked about, is access. So there are a lot of centers that can offer deep TMS, including our own actually right now, but most insurance is not going to pay for it, and it's expensive. So so maybe Stephen, we need to get you and your team to help with TMS because so far insurance companies, I don't know what it's like for you out in California, but for the most part, patients have to pay out of pocket, in order to get access to it.
Well,
just to add on.
I was just gonna say one quick point. I think it's a fantastic idea. I mean, and you could even show what is a bundled service of like you're mentioning ERP plus TMS together. How can that help people, especially folks who might not necessarily respond initially, as you were describing earlier, to ERP in different levels of service. So I think, we're looking for different ways to continuously show outcomes, and especially with different segments of the community who haven't necessarily achieved the the benchmark for a significant reduction in severity. And so we want to make sure that everyone keeps regaining hope, right? Because there are great solutions out there. It's a matter of what Dr. McAvey was saying, connecting them all together and making sure that we can help people navigate much more easily. So you don't have to go try to find, help in every different corner, right? So we could take that burden off of your plate. You have enough to worry about with just going through OCD treatment, and families have enough to go through just supporting their loved ones with the condition.
Thank you, Stephen. Absolutely. Carolyn, go ahead.
Oh yeah, I just wanted to also just raise another limitation, which is that the treatment takes a while, and if you're working, you need to go out of your business and then go kind of locally to an office and have the application. We partnered with Nolan Williams, Lee Williams, and Larry Curran to use theta burst stimulation, which is using a type of stimulation that is more natural to the brain rhythm, and to shorten the amount of time getting the treatment, and increase the dose. So just like you would with medication. And we did a small pilot study looking, applying TMS for 5 days. And in that small pilot study, we gave inhibitory. So you can either excite a region or decrease the excitement of the neurons in the region, in the right frontal pole, and found that patients had really 50% or greater responses that were durable, that lasted for four weeks, with just like 5 full days of treatment. So there are as Wayne said, TMS really didn't have that many side effects. People had like headache, things of this nature,
Dizziness,
dizziness that just went away pretty soon after the application. So again, I think it comes back to preference. One size doesn't fit all, and some people may be helped by the strategy, but not everybody was helped by the strategy.
And also, it's worth mentioning, in addition, I know Stanford and Cornell are also doing DTMS studies on to help target regions of the brain, to map the regions so they don't have to sort of guess where to put it. That's super technical, but to guess where to and be able to target and specifically target TMS to those regions of the brain, and subtype as well, regions of the brain, which is really exciting. I read that on the AOL front page, so that's how I knew that. That was a joke. Anyway, so let's see. We've got about TMS, glutamate, ketamine. Wayne, real quick, you also mentioned to me about focused ultrasound technology that you were focusing, that you were doing some work on. I'd love to hear more about that.
Yeah. So we've been doing some research using ultrasound. I have no results to share with you, but it's promising and exciting. I mentioned earlier, that it'd be great if we had, something like DBS that worked as well as DBS, could reach deep structures very precisely without surgery. So that's some of the excitement about focused ultrasound, is that you can aim a beam at maybe the same target in the brain that used for DBS, and perhaps it will be effective. Again, this is just very early research. It's really right now just doing feasibility, proof of concept. But if we're talking about the future, it is plausible that there'll be techniques like focused ultrasound where we can reach deep structures of the brain very precisely, without it being invasive, and it being very safe.
Thank you, Wayne. I appreciate that. I have some.
I have questions.
Yeah, go ahead, Liz.
Can I ask them? So,
Of course.
Carolyn and Wayne, I think one of the things that a lot of us as clinicians in the field are wondering is there just hasn't been a lot of RCTs on deep TMS and even ketamine.
Well, hey, Liz, what are RCTs?
Sorry. So there hasn't been a lot of randomized clinical trials. So this, for those of you who aren't in the research field, this is a way that we really, when we say evidence-based treatment, when we talk about that buzzword that you hear IOCDF and a lot of us saying, it means like we're promoting or we're behind treatments that have been proven to be effective or that have been really thoroughly researched and studied. And I don't know that I have seen a lot of new studies and outcomes for deep TMS, or ketamine with updated efficacy rates. Can you talk a little bit about that? Because I think it's hard because, like Ethan said, I have a hard time pitching like this could work, this might work versus this is research, this is tried, like here's what we know about it.
I 100% agree, and we just finished an NIH-funded randomized study where patients are randomized to ketamine versus midazolam, so it's a little bit stronger control than just saline, and with some of these biomarkers, and we just unblinded, and we're working as fast as we can to get that data out there with efficacy. So please stay tuned, and I'll turn it over to Wayne for the
Yeah,
DBS.
yeah. So Liz, you're absolutely right about the deep TMS. I mean, there's one large pivotal study. I think it was maybe a total of 90 to 100 patients. I mean, they did meet their endpoints. I mean, the Y box scores were significantly lower in the group that got the active compared to sham. There were some attempts at follow-up, but not a lot. I mean, that's one of the issues. If you look at the literature with deep TMS, it's not clear how long the effects last. So I think that's a reasonable criticism. I mean, it could be, it could be just the absence of the studies.
What about ketamine?
Ketamine, I would go back to Carolyn.
Yeah. So stay tuned. It is we are preparing a manuscript.
So, I mean, I think this is perfect because we're talking about the future of OCD treatment. So we know like deep TMS and ketamine could be a part of that, but I'm going to play the flip side too, right? Which is that's all to be learned still, and for us to get more information on, and it shouldn't necessarily be like the first line pitched yet, right?
No, absolutely not. And she should not. And my research really focuses on, for those individuals who first line treatments have not helped, or elect not to do those first line treatments for some reason, then that's where my research space is for those individuals. So we are not recommending doing ketamine as a first line treatment. And we've through the American Psychiatric Association, we have published some consensus guidelines, urging caution and what things to look out for if people are going down that route. And so I'm definitely of two minds. Like we need the research, but there's also people who are just in a lot of pain and suffering. And so I think both of those things can exist for those people who are just like, I'm in too much pain, nothing else has worked. I would just say, make sure that you have good informed consent, that you're researching the clinics very well, that you're getting monitoring, make sure that they're scanning for substance use, those kinds of things. But like exactly as you're saying, Liz, we need the data, right? Like it is in a larger study with randomization. How good is the blind? Sort of these kinds of questions. How good is it really?
Thank you, Carolyn. We are unfortunately out of time. We could literally have this conversation till midnight, which is why there's a part 2. So stay tuned, being scheduled, and we have some amazing guests. There really is a part 2, and there may be a part 3 and 4. You never know. But before we wrap up, I want to throw this question to all 4 of you, which is, I would like to hear a word of hope from each one of you. So, Stephen, we'll start with you.
Oh,
well, it doesn't have to be just one word. It can be a sentence of hope. Or, go ahead.
Yeah, be careful. I tend to ramble, so you gotta be careful.
True. One word for you.
One word. All right. So I just think that, look, as someone with OCD, you hear from many folks here on the panel who are deeply experienced in treatment of OCD. There's a lot that's going on that is exciting, right? And if you just look at 10 years ago, most of this wasn't really in existence. And I mean, you had ERP, obviously, and it's been great, but I think now you're starting to see different ways it's being delivered. You're seeing tons of research going in, and now you're seeing the the awareness, as Dr. McInville described, being presented more, and so it's becoming less of a misunderstood condition, right? So there's a lot of positivity, momentum right now, and I think that momentum is exciting, right? And if you have this condition and you're looking for treatment, I mean, there are people that we see who say, yeah, I've just, this started last week. And I'm like, started last week. Wow. I mean, in a week, you've been able to go and get to treatment. And I'm sure other providers see that as well, which is really exciting. And I think is a testament to all the hard work that so many people in the community have just put in over the last decade. And I know with the way things are going, it's just going to get better and better here for the next decade. So if you have this condition, it's very, very tough, and there's nothing worse than suffering with OCD when untreated. But I think there's many great ways that you can, learn how to manage. And there's a lot of great information online now too. A lot of great video content. I know there's Dr. McInville. A lot of what you've done online it's been tremendous. Same with you, Dr. Rodriguez. I know a lot of the content you've created too. So yeah, I know there's just a lot going on, which is exciting. So I'll stop rambling, and but that's my word of hope is, there's, if you just look at from the last 10 years versus where we are today, it's unbelievable to see what's happened. So
thank you, Stephen. Dr. Goodman.
So I've been in this field for a while. I think you've alluded to that, Ethan. So I've gone in to observe kind of the ups and downs in terms of interest in funding agencies, and I think we're experiencing a renaissance. I think there's an interest in government agencies and foundations, and I think it's the advocates have been very effective, many of whom are right here on this panel, in getting the word out. So I think that's very encouraging in terms of fostering research that will lead to better understanding of OCD and novel and better treatments.
Thank you, Wayne. Thank you so much. Dr. Rodriguez.
Yeah, I am, as I've told you before, Ethan, I'm filled with so much hope. And I think today I also feel a lot of gratitude, just tremendous gratitude just to be on a call with you, Ethan, Liz, and Stephen, in terms of your just pioneering advocacy and how, I mean, I just remember being as a student and trainee and just admiring all the work that you've done, and just really being called, Liz spoke about this, being called to action. Wayne is somebody who, from my very first training, I saw this like video of him, administering the very first Y box. And he's just been a beacon in the field, and really mindful of like the importance of partnering, the advocacy and research going together. So I'm just really, really grateful to be on a panel with all of you. And then I'm finally very grateful for research participants who you can never publicly thank by name, right? Because it's all confidential. And yet they're really the unsung heroes of these treatment and this work that really put themselves out there, even though they may feel like a guinea pig. They're really the key partners in this, who are experts in OCD. And we as researchers are really partners with them to try and see if these treatments are helpful. So incredible gratitude today.
Thank you, Dr. Rodriguez. And finally, Liz, word of hope.
I usually am not at a loss for words, but I remember when I took my first job, and I called my mom on the way home crying from Baylor and told her that I felt for the first time like I was doing what I'm supposed to be doing. And I will tell you, to sit on a panel that's called The Future of Treatment and like be on it is a little shocking for me. And it's not shocking because, like, we're all doing work and we're all making a difference, and we know that. But I was in the shoes that a lot of you that are making the comments right now have been in the recent past. In shoes where I didn't know if I could get dressed in the morning. I didn't know if I could take a shower. And those are the things I don't take for granted. but it's because of treatment, and it's because of clinicians who don't give up. And the message that I want to send is that my ability to sit on this panel, Ethan's and Steven's, as people who live with OCD every day, doesn't mean we still don't have hard days, and it doesn't mean we still don't struggle. But the reality is that our story should be a little bit of a story of hope, in the sense that this should be the norm. And what I want everyone to hear is that we are all dedicated to fight for that. And it doesn't really matter what it takes. It doesn't matter if we have to do it for the rest of our life. We're committed to it. And there's an entire community committed to allowing every single person with OCD to have the treatment that they deserve, so that they can have the life that they also deserve. So I'll end as I always end. Help and hope are always available. It doesn't matter where you're at.
Thank you, Liz. Thank you. And I hope you all see that you're not alone, and that people are working very hard for a better life for all of us, earlier diagnosis, effective treatment, and all of the above. So thank you, Liz. Thank you, Stephen. Thank you, Carolyn. Thank you, Wayne, for joining me and the IOCDF for this very special panel. Really, really grateful. Thank you to everyone who, our community is so knowledgeable. I was reading their comments and I was like, I don't even understand what that means. But I mean, you're so knowledgeable and so well informed. So thank you for the amazing conversation in the comment thread. I will reiterate and sort of go backwards in my end of stream housekeeping, which is, if you had a question, and there were a lot of questions, and thank you for listening tonight. We usually like to get to questions. If you have a question, go ahead, Fran. You can email the IOCDF at info@iocdf.org. Just put the subject "future of OCD treatment" in the subject line, and then just ask your question. If you'd like to ask it to a particular individual on the panel, just write the name, Carolyn, Wayne, Liz, or Stephen, and we will make sure to get you the answer that you want, depending on who you're asking. So info@iocdf.org, subject line "future of treatment," and go ahead and ask your question away. But we really appreciate your engagement and your patience. With that, I want to thank Fran behind the scenes for doing all his work that he does so seamlessly and makes us look good. And thank you to the IOCDF, of course, for hosting this panel on a Tuesday night, the Tuesday night of OCD Awareness Week. What a cool panel to have. To check out all the programming that's going on in the IOCDF during this week, you can visit iocdf.org/programs/OCD week. I don't know that I told Fran I was going to read that out loud, so he's probably going, I don't know if there's a graph, but we can go ahead and put that in the comment thread. You can check out all the programming that is happening. Also, if you want to be notified about all the programming the IOCDF is having over the next month, be sure to subscribe and follow on Facebook and Instagram. Yep, there we go. As well as, I think Twitch is going to hit Steven tonight. No, it's split Goodman and Steven. That's okay. They can share Twitch. And that's it. We'll wrap it up because I know we went a little bit over. Thank you so much. As Liz always so profoundly says, help and hope are always available. Thanks again to Carolyn, Wayne, Stephen, Liz, and myself. Have a beautiful evening. Enjoy the rest of OCD Awareness Week, and we will see you soon. Have a good night.
See you tomorrow.
Take care.